Good morning, everyone. This is Michelle Hughes from Ageless and Timeless. I have a guest today that I've been speaking with for probably 6 or 7 months, but we're booked so solid that we're finally getting to have him on. So Dr. Jeffrey Gross, welcome to Ageless and Timeless.
Thank you so much.
And you're in Nevada, right?
I am just outside Las Vegas.
Right by Las Vegas. Did you go to A4M?
Of course I did. We had a big booth there. Did you come visit?
Oh my gosh, I never saw you. Well, with 10,000 whatever it was, people there, it was difficult. But yes, I was there as well. It was probably the best conference ever, huh?
It was amazing. It was so many people and so much going on, a lot of energy, and
Right.
they need to probably add a day.
Exactly. One of the things we'll talk about today in a little bit is peptides, because I think that was one of the hottest subjects at
Yeah,
the conference, and
agreed.
they're going to be doing more and more of exploration of both stem cells and peptides. But let's start first with your background. So, I see that you went to school in Berkeley, so you were in my backyard for a while.
Yes, yes, I'm a Golden Bear from UC Berkeley,
Yeah.
way back in the 80s, and it was just as crazy then as it probably is now.
Yeah,
But
I was here. I came in '73 to Tiburon, and I went through all the violence and that kind of stuff at Berkeley and Haight-Ashbury and all that.
oh
So
yeah.
yeah, so I was here a little bit before you, but still, then you got you. So how did you go from uh, biochemistry and molecular biology to regenerative medicine, or neurosurgery and regenerative
Yeah,
medicine? How did that all happen? Give us your little
yeah.
background on your journey.
Well, I'm a nerd, so I'm always following cool science. So biochemistry was a really fun degree for me in college. It offered, a lot of cutting edge cellular, biology, molecular biology. They've actually changed the name of the degree now. It's called molecular cell biology, which makes
Oh,
more sense. Um, but that's the field where stem cells kind of reside. But at that time, stem cells were, barely a mention. They were a new concept. So then I went to medical school and then residency and fellowship, neurological surgery. The nervous system was of great interest to me, sort of the final frontier at that time, and I pursued that. I enjoyed it. I did a fellowship in spinal biomechanics. I did spinal medicine, always trying ways not to do surgery because surgery is so overdone. And that's why spine surgery has such a bad reputation, and it should, because there are real hacks out there just operating on what the MRI shows, not what the patient needs. So
Jeffrey? Why do you think that is?
it's the tail is wagging the dog, Michelle. It's the the payer mix, the scripted sick care nonsense, and the revenue from being pushed by what's called big implant. You've heard of big pharma. Well, we have what's called big implant. They make all the screws and rods to put in people. So they push it, and they push it down through the payers and through the institutions, the hospitals, and it's not patient centric anymore. It's business centric. It's the medical industrial complex. So that's why.
Yeah, so was there any one pivotal moment in your journey that made you turn to that?
No, there wasn't one pivotal moment, but I do give credit to patients who came into my office many times saying, hey, I've tried all these treatments. I've tried therapies and injections and medicines and time and yoga and all these things in my spine. My back hurts, my neck hurts. It's not better. And I'd say, well, I guess the next thing on the menu is talk about surgery. They say, well, wait a minute. I'm not that bad. I don't want surgery. I say, okay, great, because I really didn't want to have to do it. And they'd say, well, there's got to be something else to try. What about stem cells? What about stem cells? What about, you just keep hearing it. And I say, you know what? I have background in that. Instead of going to the annual spine surgery conference, I'm going to go to a stem cell conference. I'm going to start to see what's new, retrain myself. And it was eye-opening. And now, 8 years later, it's all I do.
So tell us more about that, how that works in
Well,
your practice.
yeah, we do what's called regenerative medicine. It's a strategy of using the body's own healing capability that's very robust during our youth, but it loses its oomph later in life, and we reactivate it using signals, and those signals are stem cells or stem cell signaling items like exosomes and growth factors and peptides, and we reanimate some of the body's own abilities that get clogged up with inflammation and oxidative stress over the years. And we do that strategically in different ways for different people, and we help them turn back on the anti-inflammatory healing, youthful process to help restore a joint, improve osteoarthritis, improve their body's ability to fight an autoimmune or other inflammatory issue. And many diseases of aging are related to some element of inflammation. So when we're fighting inflammation, we're putting cells back into a more optimal mode where they can do what they're supposed to.
Is there a cutoff in age that you see in your practice where the stem cells just become useless or dormant, or is it really patient individualized, right, based on lifestyle and other possibly epigenetics and other reasons? What do you say about aging as, or the chronological age as an indicator for stem cell activation?
Well, look, I like to keep things simple. I do know that you can use your own stem cells. They do lose activity and number with age, and with epigenetic lifestyle behaviors that maybe weren't ideal. And some of those things aren't our fault, right? We've been eating food and vegetable oils and things in our food source and water that we are now looking at saying, oh, we shouldn't have had these things, right? They were bad. These preservatives were bad. So, our cells and our stem cells become less powerful. So I never take my car to get it serviced and have them put the old oil back in, even if it's a new car. I always get fresh oil. So I love the most youthful source, even if you're, in your 30s and you're looking to heal a knee. I could take your own cells, but then I got to harvest them and we got to prepare them. It's easy to use some of the off-the-shelf donated biologics that are very ethical and safe, that are related to a C-section birth. So the mother gets the child, congratulations. Can we have your amniotic fluid, your umbilical cord, your placenta? You're not using them anymore. We're going to throw them away. Right. So I think that's the most efficient and most powerful way to do regenerative medicine.
Are you competing with the medical community about or advising the patient, the mother in this case, to bank their own child stem cells for future? That's one of the, the big new things that seems to be happening in that world of pediatrics.
Yeah, I don't know that we're competing for that, and I think that a lot of people are banking their new baby's umbilical cord, because you can use those tissues later for that child and for family members, and probably for anyone if they're handled properly. So banking them just improves the availability of them.
It's actually better for you for later on in their lives. It just makes the supply a little bit more, or means that you have to look a little further maybe to get those stem cells where the mother hasn't been that interested in doing that. So, but I just came back from, in November, I came back from the TAM Center in Tijuana. I don't know, have you ever heard of Ed Clay and it's the place that Joe Rogan touts on his podcast, and Dana White is I think he's an investor or whatever, but they're one of the leading hospitals, and they're doing a lot of work with cancer too, but they offer NAD IVs plus the ozone treatment plus the stem cells. And so anyway, I was the only one of 50 people that came. I went because I wanted to meet Ed, and he was coming on my podcast, and he was very kind to allow me to participate in what the other people went through. But the other 49 people were all doing injections of stem cells. And because I had, thank goodness, nothing that was bothering me, that, I was more longevity and proactive health, I did the IV. So I did 120 million stem cells. So my question to you is, in my case, I had no sign that I even did it. In the case of the other 49 people that did the injectables with the umbilical cord, the same thing that you use, they were all in horrible pain. And they had a WhatsApp link, so everybody was talking to each other even after they returned to the United States. So for weeks, it seemed that people were saying, I can't move my shoulder, or my ankle hurts. Or so my question to you is, when you do the brain part of this, does that happen, or is that also an IV? No. Cellular protection is a key component of longevity, and that's where C60 enters the conversation. Known for its powerful antioxidant properties, C60 is being explored for its role in reducing oxidative stress and supporting cellular resilience. As interest grows around mitochondrial health and aging at the cellular level, C60 continues to stand out as a fascinating area of research and application. It's exactly the kind of forward-looking wellness solution we aim to spotlight on Ageless and Timeless. For more information on C60 and how it's being used in longevity-focused routines, check the affiliate link in the show notes or use Ageless10 for 10% off your purchase of all their products.
No, we have a more advanced approach to this okay. On many levels. We don't have these type of problems. So for the brain, the best delivery, let's take a step back, actually.
Okay.
Stem cells don't last but a few days in your body.
Right.
But their benefits last well beyond that. Some of them are permanent benefits. Those stem cells, when you get them IV, 80% of them get hung up in your heart and lungs, which is great for your heart and lungs, but the rest of your body doesn't get much.
Okay, so that's me. That's my, so that would have been what happened to me. So I got great benefit in my heart and my lungs.
So probably. The stem cells are gone in a day or two, but they have delivered to your body the signaling through what we call extracellular vesicles or exosomes and growth factors.
Yes.
Well, we can skip the cells and we can go right to the extracellular vesicles or exosomes and the growth factors, and then it doesn't get hung up in your heart and lungs because they're 1,000 times smaller. They cross the blood-brain barrier. Your brain gets a bigger amount. They're more fluid throughout the body. They travel better through tissue, and that's what we're using now. That's the more advanced way to signal. Mm-hmm. They're also less costly because they're more abundant. They come from amniotic fluid. Mm-hmm. Umbilical cord is small. The amniotic sac is large, full of fluid. Mm-hmm. So these are the effect of the stem cell without the cells. Plus, stem cells have DNA, someone else's DNA. Not that we think that's an issue, but a lot of people don't like the idea of getting genes from someone else, especially after the whole COVID vaccine fiasco, which has inserted RNA into your cells. Right?
I was just going to ask you. That was my next question: is how do you ensure that these donors have not had the vaccine or the mRNA corruption in their body?
We only draw the suppliers I use, because I don't source these myself. I get them from a supplier. The supplier I use and vetted and visited the lab has only drawing from a COVID vaccination-free pool of mothers,
which is very limited.
Not really.
Okay, well that's good. I mean, I'm one of them. I mean, I'm not a mother to draw from, but I thought I was one of the big minority, given how people were coerced into getting the vaccine. But you're saying there are still plenty of people. Maybe they were just very silent, right? Those
that's true.
They were smart,
the silent majority,
particularly if they were pregnant. Yeah, so many women who were pregnant got the vaccine and have had problems subsequently. So more and more people are finding out. That's a whole other subject. But They're finding
Right.
out the side effects after the fact. Unfortunately, that this is
Right.
just the beginning of the exposure of that.
Right.
So when you go to a donor or to a supplier, how do you ensure, Jeffrey, that that supplier is efficacious?
Well, I'm glad you asked me that. So first, we look at the source, or in this case, healthy mothers screened in the first trimester on prenatal vitamins, no smoking, no drugs, only one romantic partner during the pregnancy, no COVID vaccine, no disease history. So it's a curated group, and then they're screened again at the time of birth, and they also, again, a health panel. Then the materials are handled in accordance with the American Tissue Bank accredited services, and they're on ice. They go to the lab. The lab then quarantines them for 2 weeks to check for endotoxin cultures, make sure it doesn't grow anything it shouldn't have in it. They check it for both protein content, which is the growth factors, and the extracellular vesicle count. And they only count the round vesicles between 50 and 150 nanometers in diameter. Now, all those specifications you don't need to memorize. It's technical.
Yeah.
But this is the highest current way to evaluate these type of biologics. Now, that doesn't speak to efficacy, but we know those are the cleanest and safest way to get that youthful signal. The same youthful signal a pregnant mother gets when her hair is growing and her skin is glowing.
So after you've done the placement of the stem cells in your patient, what normally happens within, like, let's say the first week or so of them having those stem cells, where they are now being somewhere transported somewhere? So what do you most frequently see as a reaction when you get those stem cells into your patient?
So intravenous, again, these are not stem cells. They're stem cell signals.
Right. I should have said that. I'm sorry.
That's okay. I got you. This is for educational purposes, so everyone gets to hear it.
Right.
We typically see improvement in energy, sleep, mental speed and clarity, recovery from exercise workouts, reduced inflammatory markers if we do blood tests, significant improvement in heart rate variability, or HRV, for those people that track it using a ring or a Whoop or a watch device, and improvement in aches and pains that have inflammatory origin. We also see reduction in biological age tests. So you effectively might get a little younger, biologically for that.
And what about dementia and Alzheimer's and other illnesses that affect the brain? Is that oftentimes the symptoms that you're trying to change and correct?
I would approach that differently, Michelle. For people with inflammatory-based brain problems, traumatic brain injury, recovering from stroke, Parkinson's, Alzheimer's, dementia has an inflammatory component. We're using nasal spray exosomes. They actually have better delivery nasal than they do IV. So people come in for a simple nasal spray and tend to have reduction in the symptoms, and our Parkinson's patients have reduction in the need for the Parkinson medications.
So what's in those nasal sprays?
The same stem cell derived exosomes and growth factors that's in amniotic fluid.
Okay, and then what about the peptides like Selene and C-Max, and
Yep.
How are you using those?
Yeah, great question. We like to stack those with appropriate peptides, customized for the individual, of course.
Yeah.
And based on, looking at labs and everything else. We don't like to add a lot of things at the same time. We like to add one thing at a time so we can really measure what's making a difference, or determine if it's a combination of things that's making a difference. So we do like to add the peptides, certain peptides for certain issues. Sometimes it's a mitochondrial peptide they need.
That would be epitalin, like, for an example, as one.
Specifically, I meant that SS31 and or a MOTS-C would be be the two most common mitochondrial specific
Right.
signaling peptides.
Well, I know I'm under Bill Lawrence, who's the peptide bioregulator guru. He worked for Dr. Cavinson, was his mentor, and if you're familiar with the oral peptides, he's the head guy in the U.S. So anyway, I've known him and he's been on my podcast, and he sent me the nasal spray for Epitalin. I think I'm saying it right, Epitalin. But
Yes.
He says that lengthens your telomeres. So telomerase is a big factor in mitochondrial or biological aging and mitochondrial
Yes.
health. So that's why I asked you.
Yes, you're correct. Epitalon is a great longevity peptide, and one of the measures is the telomere length. Although telomere length is a good thing, it by itself doesn't beget longevity. There's so much more to do. Yeah.
That's true. So give us some results that, just case study, a couple of examples of how this has changed, particularly when the peptides are stacked, because people are now more curious about combining stem cells and peptides, and then even the exosomes, like you said, and so on. So you're right at the cutting edge. So give us a cutting edge picture of what it's like to be under your care, what the patients typically is happening in a couple of your success stories.
Thank you for that. Yes. Well, I'm here in Las Vegas, so most of our patients find me on podcasts like this one, I hope. Mm-hmm. And
they will.
We start remotely, so we do video just like we're doing here. We get any imaging results, we get any lab tests, we can order things in your hometown. So we have people that are across the country, Canada, the UK, South Africa, and Australia that we've been talking to. And we only invite people here to our home in Las Vegas if there's something we can do for them, if there's a reason. Not everyone's a candidate. Mm-hmm. Most of what I do, because remember, I'm a recovering spine surgeon, is I do joints and spine. So we isolate a pain generator that has an inflammatory component.
Right.
We do very high quality MRIs, not just a run-of-the-mill MRI.
Right.
And I like to be involved in that, because I know how to order off the secret menu on MRIs. Mm-hmm. And then we target off the MRI, and then we bring people here. So let's say it's a knee. We do a lot of knees. Knees are the low-hanging fruit. Mm-hmm. So we bring people here. We already know what we're going to do, and we do the injections per a European protocol. And that protocol calls for us not to inject the joint, but to inject the bone edge above and below the joint. And the reason for that is, one, the cartilage we're trying to stimulate and regenerate is made in the bone, just like our hair is made in our scalp follicle, but sent out of our scalp to hang on our head. Our cartilage is made in our bones. So injecting the cartilage where there are very few cells isn't so useful, and that's why those patients in Tijuana are getting so inflamed, because you're putting a bunch of cells in their joint, which is called arthritis. You're giving them a temporary cellular arthritis. So we inject the bone edge. Of course, we do that under some light sedation in a surgery center. I use fluoroscopy, and we target off the MRI. I match the fluoroscopy, and we go right into the spot. The procedure doesn't take long at all. People have a little bit of soreness for up to a week, but there's no downtime. So it's nothing like the people you experienced in Tijuana, and there's nothing wrong with what they're doing. It was tried and true in the 2000s, 2005, 2010, and a lot of clinics still do it because they're not equipped or knowledgeable to catch up with the European literature, where there's 15-year follow-up publication showing that the bone edge injection is years superior to the joint injection. So that's what we're doing. We're doing this at the highest level, at the most advanced level. And we stack that with a cartilage regeneration peptide and a Wolverine stack. So it's BPC-157, TB-500, Cartilax at a good dose, and it's injectable subcutaneous. The oral is not bioavailable enough for this purpose.
That's a good point. That's really helpful, Jeffrey. I was told, this is just a question for you, but I was told that, because I know the Wolverine stack very well, but I was told that TB500 is less expensive, but not nearly as effective as thymosin beta 4. What are your thoughts?
From a musculoskeletal perspective, I haven't seen head-to-head comparisons to be able to speak to that. The Wolverine combo is so affordable anyway
Right.
that I don't think it's a big deal. We love thymosin peptides for immune health
Yeah.
and prevention. I love TB500, which is thymosin beta, in the Wolverine stack because it's angiogenic. It supports the development of blood flow. So you need that when you're regenerating tissues. So the BPC is heavily anti-inflammatory. The TB500 is heavily angiogenic. You put those together, you get the synergy. Add the Cartilax for the cartilage regeneration. Make sure you're getting good protein intake, creatine, and a good amount of protein. And then you need to mechanically stimulate the joint. We want our patients who have these injections to be using the joint the next day. It's the mechanical stimulation, and mechanoreceptors need to feel that to stimulate the process.
And what about the people that have already had a surgery, and maybe they have titanium in their joints or wherever the surgery was? How do you deal with overcoming the metal of the titanium in getting to the place where they're going to heal, or do they have to have the titanium removed before they can even begin with you?
Yeah, so unfortunately, if you've had a knee replacement, you've got titanium, there isn't an approach that we have for those people, and very few people, if anyone, is going to have that removed.
Yeah.
So it's unfortunately, they've burned the bridge once they've had the replacement.
Okay, but you can have it removed. If a person says, okay, I'll go back and take this out now, it's been a few years.
No.
They can't do that.
No.
Oh,
If we speaking to a knee, they remove your meniscus and your cartilage in the bone, part of the bone, to put in the artificial knee. So no, you can't have that out.
okay.
It leaves you with a big wobbly nothing.
What about if it's in another place, like an ankle, like a tibia and fibula type of thing?
If it's a true replacement, it's
No, but that's not true replacement. That's just tibia and fibula being broken and being supported, right, by the titanium.
Oh, okay. So now you're talking about like a fracture repair hardware.
Exactly.
Yes, we prefer that be removed as soon as the fracture is healed.
Yeah.
We don't like retained hardware. That does put additional stress at the joint, and it's really begging for advanced and accelerated arthritis development. When we say arthritis, we're saying post-traumatic degenerative arthritis. I hate the word arthritis because it's so misused by doctors and others. Yeah.
But okay, so what if somebody says, okay, I've waited a couple of years to do this procedure, and so I've had the injury, the insult, but I haven't done, I've injected BPC, let's say, into the joint because I've heard that would work, but it didn't work for me. I'm just giving you hypotheticals. So what would you tell that patient how to, that's been kind of band-aiding it without going to the step of meeting with someone like you?
Well, most people are trying different things first, and that's okay. We're not doing peptides in the joint. I've not seen evidence that it is any better than injecting it subcutaneously into your belly fat.
Yeah.
So we recommend subcutaneous injection or nasal spray depending on the application.
That's really a good point because like stem cells that are pluripotent, do the peptides, that, let's say BPC 157, just to use that because that's the most commonly known. If you injected sub-Q into the abdomen, does it have a brain to know where to go, just like stem cells do, to the place that needs the healing?
No, peptides go throughout the body.
They're signaling throughout the body.
Right, but where you need it most is where you'll hopefully feel the most benefit.
Okay.
That's not to say it may be helping prevent and help you in other areas as well, so why not do that? But just to clarify, stem cells, there are different kinds of stem cells. We're not currently using pluripotent stem cells.
Yes.
those are, we don't, we're learning about them. There are certain applications in the cancer realm.
Yeah.
We are using, what was called multipotent stem
Right.
cells. Okay.
Yeah, I understand that. So, but maybe explain the difference to people, because not everybody understands that. So if you could take a moment just
Yeah,
to tell everybody
of course.
what that difference is.
So when you're a fertilized egg inside of your mother's womb, you're made of one omnipotent stem cell, and that develops into a fetus that has limbs and things, and the cells there can still make a body and organs. Those are pluripotent. They have a lot of power, but not as much as the original embryo. And then eventually, when you come out and are born, you maintain mainly multipotent stem cells. So they can't go back and form a limb, although we're learning potentially how to do that. But they can help replace and regenerate tissue and stimulate your body's healing. Those are called multipotent. And that's
Right.
really, from a therapeutic perspective, what's out there here, available, except in a few isolated research-controlled situations where we use induced pluripotent, where they're nudged backwards with some tiny growth factors called Yamanaka factors.
That's right. I know all about them. Yeah. So talk about those for a moment. I'm glad you brought that up, because there's more and more on the internet now about the Yamanaka factors, and I don't think everybody understands how important that study or that revelation was and how it got ignored. So could you go through that for us, just to give us a little history of what's happened, what did happen, and what is now happening?
Yeah. So Dr. Yamanaka isolated what it takes to take a cell and move it back into its stem in its pluripotent origin. And so you're moving it backwards along these embryonic lines, and you can do it with 4 little growth factors that are called the Yamanaka factors. And so you give it these.
Why do you think it got? Why? I'm sorry to interrupt you. Why did you get it suppressed over these years? Why has it not been more groundbreaking and utilized?
If you were a company that made billions of dollars selling chemicals to sick people, you wouldn't want to find the fountain of youth.
Yeah.
And of health. Yeah.
So so they didn't find that. The pharmaceutical companies weren't able to patent the Yamanaka factors as a.
Oh, I'm sure they're trying.
As a
I'm
drug.
sure they're trying. Yeah.
Okay. Well, follow the money, as we always say. This is the problem with our healthcare system, right? That we're not looking to cure the root cause, but yet we find lots and lots of drugs to try to address symptoms.
Yeah. We could talk another hour on that. Yeah. I'll just cut it off there, because there's so much I could say.
I try to keep this podcast apolitical, even though I have my opinions, but I
That's
do,
okay.
I try to keep it as neutral, as more educational rather than political. But obviously, I have a strong belief in regenerative and functional medicine. That's why I do this, because I want people who are still practicing in the traditional old-fashioned way and getting no help, no results, to understand that there are solutions, but you have to look further into what people like you are doing. So that's really 7 years ago when I began this podcast. That was really my goal, is to help people, is to be almost a philanthropic resource for people to have more. Information is power. So how is AI and robotics affecting what you do?
Well, AI we're just tapping into that, right? So sometimes I will use AI to help find patterns and things I can't see, because a doctor is a pattern recognizer, but sometimes that pattern's not obvious. So we'll put labs in. We'll say, hey, help me out here. What's a list of things? And you might find something you didn't consider. So we use it to open our minds. Hopefully people do. I use AI also to save time. Help me. Here are some notes I made on a patient. Please put this in a nice paragraph form or something like that. That's simple.
Right.
We're using, our company's using AI to find new peptides that bind certain receptors. So that's really neat. And I just came back from a health tech summit a couple weeks ago in your neck of the woods in the city, and we there was a lot of talk on how to employ AI better in healthcare and use. And I think what we're going to find, at least in the next year or two, using AI to read an X-ray or an MRI or a pathological specimen is going to have more efficiency and more thoroughness than we've ever had, and speed.
And what about robotics?
So robotics, I trained a little late after robotics came through. I know I have colleagues that use robotics. And in the spine surgery realm, I went to see a robot used to help with spine surgery. It's a great way to take a surgery and add 3 hours to it. So, until it becomes an efficiency generator, it's going to be held up a little bit.
And so, but yet they're using it for heart surgery and for things that are a lot more, just being demean what you're doing, but let's say a heart surgeon like Dr. Gundry, I mean, that's life and death. You would hope
it can be. Yeah, it can be.
Yeah.
Not that brain surgery that I used to do wasn't either.
That's
and
true.
We used to tease the heart surgeons. They're just there to make sure the brain gets supplied.
Yeah. No, I was thinking not so much brain surgery, but like knee replacements or.
Yeah, that's fair.
Yeah, that more of the joint and muscle issues that you also deal with. So, tell us about the Muse. You gave me a list of topics, and I didn't know what that was. So, could you explain that to us and how you're using that? The Muse, yes. Muse stem cell, MUSE.
Yeah, so as I alluded to earlier, there are many types of stem cell. I gave you the overarching headings.
Yeah.
Turns out there's a subset of regular umbilical cord stem cells, which are mainly MSCs, called MUSE, M-U-S-E, standing for multilineage, undifferentiated, stress enduring. So they're a little bit better, and they have more potential, and they're smaller, so they'll travel better through tissue. So we're just now learning how to apply these. They become popularized, because the Kardashians got some. But we are just gaining access to them, and we are expecting to be trying them in some of our challenging areas. So, for example, the spinal disc is difficult to regenerate, even with regular MSCs or exosomes. We have benefit using those biologics in the spinal bones and in the spinal joints, but not so much in the disc. But there was a study out of China, and they do try things there early, where they used Muse cells and showed some disc regeneration. So we are looking to begin, as soon as we get our hands on these, which hopefully will be the next few months, a disc sandwich therapy. We'll do Muse cells in the disc, in the nucleus of the disc, because that's tissue of what's called endodermal origin. And then we'll use typical MSC-derived exosomes and growth factors in the bone edge, as we have been doing traditionally, to stimulate the disc annulus and the end plate health. And that sandwich therapy, we're hoping, is a breakthrough in our ability to improve the health of our discs.
And where do those cells, the Muse cells, come from versus the ones that you have been using from the umbilical?
They also come from the umbilical source, but they have to be carefully teased out because they're, maybe 1% of them. So that's where they become difficult to collect enough. It's like panning for gold. You have to sift through a lot of riverbed to find enough gold, to make a nugget.
Mm-hmm. And so I'm not sure I'm really understanding the differentiation between how they make a difference and how the stem cells you've been using make a difference. So what is it that they are that make a difference?
They can stimulate different tissues in our body better than regular MSCs do. Yeah, and again, challenging areas like the disc, like hair growth. We have some benefits from using exosomes and stem cells in the scalp for hair growth, but there are still challenging cases, and we think the Muse cells are going to move that along for us. In addition to the right other health, aspects and lifestyle factors and peptides and what have you.
Got it. Okay, that helps. Thank you. I don't think anybody listening today or watching today would even have known about those muse cells. So this is something that everybody can learn from, and even ask if they need this help. They can ask their practitioner. So, okay, let's move on to another subject. What, in your practice so far, you've obviously made a big transition from molecular biology to regenerative medicine and away from surgery as much as possible. Has there been any incredible insight or learning experience that you've had in your journey to do that, to make those changes? And along with that, correlating, has there been any failure that has taught you some great lessons? I know that's kind of like double whammy.
That's okay. We can handle compound questions. The first one is, I think that you look at root cause analysis, and it's amazing how much inflammation plays a role in degenerating the effect of our cells, and how we can biologically signal through regenerative biologics, through peptides and other ways, through lifestyle, to slow and even reverse that inflammation for health and longevity benefits. So I think that's the aha moment that we lost sight of. We probably learned it in medical school or before, but we lost sight of it. We're so busy treating knee pain or back pain, or so that's the root cause piece there. And the failures would be in doing surgery when for all these years, and in the right patient, and doing it as best as I could, when I could have been offering them regenerative medicine options. Because informed consent, the doctrine of informed consent, means a doctor has to tell a patient all the possible options, review the risks and benefits, the pros and cons, and help that patient make a good decision.
Right.
An educated decision. If we're not giving them all the options, we are violating that doctrine.
Exactly.
So many doctors who are not including these options, and we don't have to offer the option. If I don't do a certain thing, I can say, listen, this is an option. I'd have to send you somewhere to go get that.
Right.
That's okay. We should be doing that, and so many are not. They're just doing what's scripted, or in some even worse. Sorry, ma'am, I really want to do this surgery, but the insurance will cover this other one, so we'll do the one they'll cover.
Right.
That's disgusting.
Again, the sickness of our system. That people can only do what they are covered by insurance, and oftentimes insurance is not covering the very protocols that they would benefit the most by.
Correct.
It's crazy. I hope that RFK can do some things that his position to modify, or at least dramatically change that. But okay, so in the stem cell world, is there anything that's happening besides these muse cells? Is there anything else that's happening that it's exciting you, that you found out about when you went to this conference or otherwise?
Oh yeah. Well, so in the next year or two, the phrase stem cell will be too vague to use. We'll be talking about, what tissue-specific stem cell? Is it a neurologic stem cell? Is it an exosome derived from a neurologic stem cell? I just ordered my first batch of what's called dermal papilla exosomes, which are specific for the follicles in the hair that have a enhanced cargo and signal for hair growth on top, compared to a generic exosome. Nothing wrong with generic exosomes. They're healthy, they give a good signal. But if we can dial that signal in even better, it's like dialing in the old UHF TV to get the signal just a little tighter. That's what we're going to be hearing about. Yeah.
I didn't realize that you were working on the scalp. I mean, that's a huge area, because particularly for women after menopause. So talk a little bit about the patients that you have, and what kind of results you've gotten from the hair growth standpoint. We use a lot of MSC derived exosomes and growth factors, the amniotic fluid products, in the scalp and in the face for cosmetic. It's really an enhanced vampire facial, right? Because a vampire facial, you take your own PRP, your own blood, and you inject it in the face or the scalp, and those can be beneficial. But the
The exosomes are even more beneficial typically. We like to use a fresh frozen variety. I don't like the powdered lyophilized because you lose a lot of the growth factors. You lose some of the exosomes when you powder them. So we use fresh frozen. We have a special freezer. We keep all that in. And we have variable results. We inject the scalp. We inject the face for rejuvenation of the skin quality, especially like you said, after menopause. There's skin dryness, itchiness, flakiness, redness, and we want to improve the skin quality. We're working on a cream that you would keep at home in the refrigerator that would be the same amniotic contents in a cosmetic product. And that should be launched here in the next couple of months. But you have to keep it refrigerated because these things are viable. They're biologically active.
Right.
It's not going to be something you're going to get off the shelf at Sephora.
Right. And so to do the treatments you're talking about, obviously people have to travel to Las Vegas to your clinic, right? And to do that, I mean, this is not, you can't just use the cream at home as a Band-Aid without having
you can.
Oh, you can?
No, you can use the cream at home once it's available. We don't have it yet in market. We will.
Okay.
You can order that. It'll be cold shipped. We're figuring all those details out.
Okay, good.
Yeah. We're trying to come up with a name, so if any of your listeners can help us out there.
Yeah.
So many people are scooping up all the good website domains, so we want a name and we can get the domain, So we're trying that. But that should be launched very shortly, and that's separate or in addition to the procedures. The procedure are just microneedles. So we do microneedles, and then we put on the exosomes, and sometimes we'll put a little hyaluronic paint on top of it just to seal them in.
Right. Well, that's exciting. I was a part of your practice I had no idea you were doing, and so there's lots of people that opens up a huge floodgate of people who might be interested in contacting you about your procedures, because there is so much money spent on hair replacement, but with no results. Yeah. People are frustrated.
Hair is multifactorial, hormones and inflammatory burden in the body. There's so many things we look at for that. And, we have great success in some and not as great for others. That's why we're excited to try these dermal papilla exosomes for the more challenging cases, or the Muse cells for some of the more challenging cases. So we will have different things worth trying as we progress in gaining knowledge and understanding in the field of regenerative biologics.
So how often do they have to have those treatments to make a real impact?
Well, we usually do them in a series of 3, separated by 4 to 6 weeks, if we can. Of course, people traveling in can't always do that. But it does take a number of weeks or months to see the growth spurt through the top, the scalp and start to come in. And oddly, some of these have a temporary shedding phase. So you actually lose a little hair at the beginning, which can be quite daunting. So we're gaining more understanding there so we can advise people what to look for.
Mm-hmm. So, Jeffrey, before we have to go, because they just signaled me, I want to ask you a personal question. What are your daily habits that have kept you healthy and not needing all these procedures that we're talking about?
Well, I do intravenous exosomes quarterly, just for preventative purposes. I do. I'm very good with making sure I'm getting a good weight-bearing exercise. Lifting heavy, using my muscles, working the core. I also try to have a nice sleep hygiene, cooler room, turning off the screens early. I intermittent feed. I'm a guy who easily doesn't have to eat until lunchtime, and we're filming this now. We're approaching noon here in the Pacific time zone, and I'm just now thinking, I could go for something. I haven't had any.
I'm exactly the same way, and sometimes I finish my last meal by 7 or 6 even. Yeah. And I don't eat again until the next day at this time. So, I'm getting like those, 18 to 22 hours of intermittent fasting.
Yep.
Dr. Anton, who is a guest on my podcast, he runs the El Nutra, which is
Yeah, I
Prolong
know who he
Health.
is.
Yeah,
Mhm.
they have the fasting with food. But he says you shouldn't do more than 16 hours. But I don't know. For me, I find that longer doesn't make any difference in my muscle, atrophy, or my the mTOR or any of the
Yeah,
autophagy. It just seems like it doesn't make a difference whether it's 16 or 20
yeah,
hours. It's just
yeah.
I just feel better when I haven't had to digest.
Yeah, I listen to my body. When I get hungry, I'll eat something, and I'm not eating much because the rest of my regimen, and I could make a longer list, but I take
Yeah,
supplements. But we do peptides, so I'm on a low dose retatrutide. Some
I am
people
too.
call it retatrutide.
Yeah,
That's fine. Call it what you want. I call it Reta, or for fun, I call it Stretatrutide because it
yeah,
really is, giving me abs again. And
yeah.
so that I've been on now. I've been on a GLP of some form for about 3.5 years,
Hmm.
and I love just not being hungry all the time. So that's been
Right.
great.
And so you
And when
microdose it. How is it? 10 ml? Do you do
I don't
10?
know if microdosing is the right word.
Okay. Well, how much do you do and how often?
I'm on 2 milligrams a week.
Okay. Oh,
Um,
that's very low.
it's a
Well, no,
low
wait,
dose.
2 milligrams. Okay, I only know it by the insulin needle. So, what's 2 milligrams daily on an insulin needle? If you were doing it, you don't know. This is where I
Depends
get
on your
confused.
concentration.
But 2
Yeah,
ml is what you've
yeah.
done.
And for those of you out there in the peptide world, if someone asks you your dose
Yeah.
and you tell us in units, we have no idea what your dose is.
Oh,
You have
okay.
to tell us how many milligrams are in the vial, how
Yeah.
many cc's of fluid you use to make it up. Then we know your concentration and we can
Yeah.
calculate the,
Right.
the dose. So we do retatrutide, we do Clo with copper, so that's BPC 157, TB 500, KPV, and TB and
CHK.
copper,
Yeah.
GHKCU.
Yeah. I
And
do the same things.
we do a low dose. My wife and I do a low dose every night, and then we do a higher dose nights of need. If we're taking the kids to Disneyland, or the grandkids to Disneyland, and we're going to get 25,000 steps, we're going to take a higher dose that night.
I got it.
So we dial it up and down. I do take ipamorelin CJC 125 for muscle
I do too.
maintenance. And then I have been using a little melanotan too.
Hmm.
I'm usually very, very pale, especially
Hmm.
on the podcast. The light whites it out.
Hmm.
But I have a little bit of freckles and color now because of the melanotan.
Yeah, that would be the last thing I should ever do because I have so much melanin. But I know the value of it for people who
Yeah.
are of, let's say, Irish descent and they want some more tanning. But I'm more Mediterranean, so I stay away from that. That's the one peptide that I
Yeah.
don't do. But I try all the other ones you mentioned. I am using. So, but I try to keep it to like a very low dose of everything. But at least I'm getting something.
Yeah.
So, well, I know our time is up, and I want to thank you for sharing all this incredibly valuable information. I'm glad we finally got our chance to have this exchange. Is there anything you want to say in parting ways to our viewers? Any last minute pearl of
Yeah.
wisdom?
Yeah, thank you for having me, Michelle. So everyone out there, you don't have to spend a lot of money to live longer. Exercise hard, breathe deep yoga breaths
Hmm.
periodically. Get up out of your chair or out of the couch, move around, do some squats, exercise snacks. Try to avoid the seed oils. You can do this. You can live longer.
Yeah,
And
and sleep is an important one too.
sleep is, I agree with
Right.
that too. Yeah.
Okay. Thank you. You have been a great guest. It's been a pleasure having you on the show and sharing the conversation with our audience. To everyone listening, thank you for tuning in. If you enjoyed this episode, be sure to subscribe, share it with someone who would benefit, and join us again for the next conversation. Until then, take care and stay well.